The following podcast is part of a certified educational activity titled Tackling CRS with NP Management with Emerging Biologic Therapies Targeting Epithelial Cytokines. Game On. Access the entire activity and complete the post-test at peerview.com/ZYK860. Downloadable slides and practice aids are also available.
Hello, and welcome to this activity on managing chronic sinusitis with nasal polyp with new and emerging biologic therapies targeting epithelial cytokines. My name is Joseph Hahn from Old Dominion University, and joining me today are Dr. Katie Buchheit, Dr. Stella Lee, both of them are from Brigham and Women's Hospital, and we have Dr. Thomas Higgins from Kentuckiana ENT. The goals for today is to improve your understanding of the role of epithelial cytokines in chronic sinusitis with nasal polyp and the rationale for biologics targeting these cytokines. It is also to enhance your knowledge on the efficacy and safety of biologic agents targeted at epithelial cytokines for the treatment of chronic sinusitis with nasal polyp, and finally, provide guidance on selecting patients with chronic sinusitis who may be candidates for the treatment of these biologics. So with that, I'd like to turn it over to you, Katie.
Great. Thank you so much. So I'm going to talk about pathways to progress, epithelial cytokines, and driving CRS with NP and the need for targeted care. So in terms of chronic rhinosinusitis classification, about 20% of patients with chronic rhinosinusitis have nasal polyps. And this is often associated with high levels of tissue eosinophilia and really what we call kind of classic type 2 or allergic type predominant inflammation. 80% of patients with CRS have CRS without nasal polyps, and they tend to have a little bit more heterogeneity in terms of inflammation. They'll often be associated with type 1 or type 3 inflammation, which is mediated by things like interferon gamma or IL-17, but also can have type 2 inflammation, and they may overall have less eosinophilic infiltration. And, it's really important to think about patients with any history of reactions to NSAIDs or aspirin, any medication that inhibits COX-1. Those patients should be evaluated for a possible diagnosis of aspirin-exacerbated respiratory disease, as that's associated with very severe chronic rhinosinusitis with nasal polyps. So thinking through the inflammation that drives chronic rhinosinusitis with nasal polyps specifically, we often think about the exogenous insults impacting the epithelium. So this may be something like allergens. It could be infections like viruses or bacteria, proteases, pollutants, or particulate matter, which can drive inflammation in the epithelium and release of these innate type 2 inducers, IL-33, IL-25, and thymic stromal lymphopoietin, or TSLP, which can then go on to drive ILC2 and sometimes Th2 cell production of the canonical type 2 cytokines, things like IL-4, IL-5, IL-13, which I think have very well established effects in driving class switching in B cells to IG producing cells, which can lead to mast cell activation. IL-5 is known to drive tissue eosinophilia, sort of recruitment and survival of eosinophils in the diseased nasal polyp tissue. IL-13 has many roles in terms of inflammatory cell recruitment, mucus responses, airway remodeling, certainly. And we know that the type 2 cytokines can really feed back on the epithelium to drive even further dysregulation and increased production of these alarmin or these innate type 2 cytokines, driving sort of a feed-forward loop here. Really, we've learned a lot about what's driving chronic rhinosinusitis with nasal polyps over the last several years with really, I think, amazing translational efforts. This is a study that used bioinformatic immunophenotyping of diseased human tissues, shown here. And what was really interesting is they identified a population of Th2, type 2 helper cells, with features of really chronic activation, and they called these the Th2 multipotent progenitors. And what they found was that these cells can self-renew and they can differentiate into a variety of different T cells. T effector cells, regulatory T cells, follicular helper T cells. And this is really thought to be important in sustaining this allergic inflammatory response or this type 2 response. And I think what's really interesting is that the Th2 multipotent progenitor cells persisted with IL-4 receptor blockade. However, TSLP actually drove the expansion of these progenitor cells and also rendered them insensitive to glucocorticoids and apoptosis in vitro. So, there may be a role in TSLP in really driving these multipotent progenitor cells, which can sustain allergic disease. So we're moving into a time where there are now a variety of available respiratory biologic medications for chronic rhinosinusitis with nasal polyps. And this is just a look here at some of the currently available agents, what they're blocking in terms of the cytokine or mediator cytokine receptor, and what that may do at the level of different cell types. So, we talked a little bit already about how IL-5 impacts eosinophils. So IL-5 receptor blockade or IL-5 blockade can have impacts on eosinophil differentiation, survival, and activation. But blocking IL-4 receptor, Ig, and TSLP can also have impacts on eosinophils. In terms of impacts on basophils, there's some data suggesting that blocking IL-5 Arts receptor can have an impact on Ig proming. Blocking IL-4 receptor can have impacts on basophil survival and Fc-epsilon-R1 expression. Blocking IgE can have impacts on both mast cell and basophil activation, degranulation, mediator release. And then blocking TSLP can have impacts on both basophils and mast cells as well. And then we see that, there are well-established effects of what blocking IL-4 receptor can do in terms of the epithelium, and established effects of TSLP and its impacts on epithelial health in terms of amplifying this inflammatory response, including increased TSLP release. And then there are known impacts of these cytokines and receptors on B cells and plasma cells, which are abundant in the polyp tissue, and even airway smooth muscle cells, and macrophage and monocyte polarization. So, I think it's important to kind of think through the mechanisms of how these medications are working and the different cell types that they're impacting. So in terms of TSLP and chronic rhinosinusitis with nasal polyps, we know that TSLP, mRNA, and protein levels are elevated in the epithelium and in the nasal polyp tissue and can induce the production of type 2 cytokines, as we talked about. The production of TSLP by epithelial cells is controlled by both innate and adaptive immune signaling. We'll look a little bit more at that. And targeting type 2 inflammation in chronic rhinosinusitis with nasal polyps, especially with TSLP, can reverse structural changes in the nasal polyp tissue through reprogramming of some of these structural cells. And this is just a look at tissue mRNA levels of TSLP and TSLP receptor in the polyp tissue compared to uncinate tissue from healthy controls, patients with chronic rhinosinusitis with nasal polyps and chronic rhinosinusitis without nasal polyps. And we see that the TSLP mRNA levels are highest in the polyp tissue itself, and that it correlates with the TSLP receptor. Looking a little more detail at patients actually specifically with aspirin-exacerbated respiratory disease, so a very severe phenotype of chronic rhinosinusitis with nasal polyps, we see that whole polyp TSLP levels of the cleave active form of TSLP, as shown on the top right, are significantly higher in patients with AERD compared to patients with aspirin-tolerant chronic rhinosinusitis. And you see in the Western blot that there is much more of this cleave active form of TSLP in AERD. So, certainly potentially having a role in driving disease severity in patients with AERD specifically. So, we know that TSLP is produced by the epithelial cells. It's found in both the upper and lower airway mucosa. And this upstream signaling pathway can activate both type 2 high, type 2 low inflammatory pathways across a unified airway, supporting the idea that one biologic in a patient can potentially target the spectrum of type 2 inflammation. And in this figure here on the left, we see proposed biologic mechanisms that are involved in TSLP blockade in patients with chronic rhinosinusitis with nasal polyps. So, as we discussed before, TSLP is produced by the epithelial cells, And in blocking TSLP, this can have impacts on a variety of different downstream pathways. It can prevent the Th2 cells, ILC2s, from producing type 2 cytokines, IL-4, IL-5, IL-13. It can also have potential impacts in terms of eosinophil activation and survival, have potential impacts on mast cells and their mediator release. So here in this figure, we see that they, specifically show TSLP may have impacts in terms of blocking the pro-inflammatory cytokine PGD and mast cell production of type 2 cytokines like IL-5 and IL-13. So a variety of different potential impacts in terms of TSLP blockade. On the right-hand side, this is showing kind of some hypothetical mechanisms of polyp regrowth. So we see that, again, we have these, in the nasal polyp tissue, there are these beta cells that are really locked in this uncommitted progenitor state, which is quite dysregulated. And in this type 2 inflammatory kind of access, there can be epigenetic changes that really persist. And this type 2 environment can basically cause alterations in this beta cell phenotype. An important potential player here is this ALOX15 access, or the 5-lipoxygenase access, which can produce a whole variety of pro-inflammatory lipid metabolites. Catalases are thought to be important here. And then sort of downstream of that, eotaxin, which can play a really important key role in recruitment of eosinophils in the polyps. So we know that ALOX15 is expressed in polyps, especially in basophils, and can be induced by both IL-4 and IL-13. And then, if we look at the third part of the figure, these cystatins, they're overexpressed in the nasal polyp epithelium. They can be secreted by exosomes. And we know that stimulation of TSLP can really lead to increased pro-inflammatory feedback loop, where there's enhanced eosinophilic inflammation and activation and formation of these eosinophil extracellular traps, as shown here. So, this is certainly a potential, I think, important proposed pathways in how this inflammatory feedback loop really can self-propagate, and also how TSLP can play a role here. So with that, I'll hand it next over to Dr. Stella Lee.
Thanks, Dr. Buchheit, for that excellent overview. Next, let's talk about some of the biologic breakthroughs evaluating the evidence on current and emerging treatments for CRSwNP. Some of the traditional treatment approaches include topical nasal saline irrigations, intranasal steroids, and every which way we can deliver them to the sinuses. This is maintenance treatment. So patients are asked to spray their nose with intranasal corticosteroids. There's an exhalation delivery system. We have steroid-eluting implants that we place in the office and in the operating room. We also do off-label ways of delivering the topical steroids through either rinses or through drops. And then for antibiotics, we know that this is not a mainstay, but that it can be helpful when patients have exacerbations of CRSwNP. However, the evidence is lacking, especially for type 2 disease. There are other medicines like glucotriene modifiers, montelukast or Xyluten, which can be helpful, especially in our patients who have AERD or aspirin-exacerbated respiratory disease. And then systemic steroids, they are helpful in patients, but we really try to avoid using them because they have significant adverse effects on patients, and that can be cumulative and toxic. So sinus surgery, when is it helpful? We really lean towards functional endoscopic sinus surgery when we try the medical treatments, as I mentioned, the topical steroids, the rinsing, antibiotics if necessary, and patients are still really symptomatic. They're having trouble breathing, smelling, with drainage. They're having a lot of facial pressure, and then also their sinuses look blocked and opacified on imaging, and nasal endoscopy shows significant polyp burden, for example. What are the goals? We don't have a cure for this disease yet. So the goals of sinus surgery are to allow for better access for topical drug delivery, which means that we need to decrease the polyp burden, which means removing the polyps, reestablishing carefully the sinus outflow tracts, and then the tailoring and the precise nature of surgery, we should really consider what the goals for each patient are and what the symptoms that are most bothersome to patients are. So that's really important. Make that decision together. And then afterwards, also really important to discuss with patients that the surgery, I say it's not like an appendix that we take out and it's gone forever. We do the surgery in order for then the patients to be able to access the sinuses by applying topical medications, including the topical steroids. We know that surgery is a way for delivery for medications, not a cure. We know that there is a high rate of recurrence for some cohorts of patients. And especially the important takeaway is that patients who have comorbidities, especially allergic rhinitis, asthma is the big one, and also AERD, those patients have the highest polyp recurrence. So if you look at some of the recurrence ranges, it can range from 10 to 40%, depending on what population study. So there's a lot of heterogeneity in that. Some of the older studies you can see here, as high as 40%, 18 months after surgery. One caveat, however, is that in some of these studies, although they see polyp recurrence, that doesn't necessarily mean that the patients were symptomatic. So it's important to recognize that the polyp, you can have return of polypoid disease in a large fraction of patients. There are some more extended approaches, such as the draft 3 procedure, where we connect the frontal sinuses, for example, and create a more wider opening to the frontal outflow tracts. That has decreased polyp recurrence rates. And we know that patients who have not only type 2, but also mixed inflammation, like neutrophilic inflammation, they have more severe sinus disease and also symptoms and recurrence after sinus surgery. Now we have biologic therapies. It's a newer paradigm for us since 2019. Besides just the topical medications, the leukotriene inhibitors, antibiotics, and sinus surgery, steroids, we have biologics. So you can see the different biologics: dupilumab, omalizumab, mepolizumab, and tezepelumab. Dupilumab and tezepelumab are approved for patients as young as 12 years of age. And you can see the other indications. This is really important because right now we don't have a great way to establish which biologic is best for which patient. That's a question that many of you ask, and the other indications can help us to decide. If patient has a comorbid atopic dermatitis, then dupilumab might be a better option for that patient. The patient has also severe food allergies or chronic spontaneous urticaria, omalizumab might be a great option. Also for patients who have EGP, or eosinophilic granulomatosis, polyangiitis, and eosinophilic asthma, mepolizumab may be a better choice. And then also we're learning more with tezepelumab too. There are patients who have asthma, but also type 2 low and type 2 high. These patients who are on tezepelumab may with lower eosinophils may do well with tezepelumab as well. So we are hopefully with real world data becoming more sophisticated in how we decide which biologic is best for which patient. So going to comparing the biologics for CRSwNP, these are the really important key clinical trial findings. So let's go over them. The first column, you see Liberty, the nasal polyp sinus 2452 study for dupilumab. Then the middle column, you see omalizumab, the polyp 1 and polyp 2 studies for the phase 3 trials. And then Synapse was the phase 3 trial for mepolizumab. So the first row are the nasal polyp scores, and the second row are the nasal congestion scores. You can see that for all 3 biologics, there was a significant improvement compared to placebo for the treatment group for dupilumab, for omalizumab, and mepolizumab compared to placebo. And that's what also not only do you need an objective score, you need a subjective score. So the nasal congestion score, also you can see there's significant improvement in the treatment group compared to placebo for the 3 biologics that are approved for CRS with nasal polyps. Some of the adverse events that we see in real world studies, the most common that we are seeing in our clinics, we can definitely point towards arthralgias. Other side effects potentially are rashes. To be more specific, we are seeing more type 1, 3 potentially activation or unmasking for these patients. Um, so patients have joint pain, for example, and have psoriatic exacerbations. However, with that said, a lot of patients, at least in my practice, do find that the biologic treatments are so beneficial to them that they will tolerate some of these side effects. Although in some patients, you will have to, decide whether it's these adverse events are a reason to discontinue or change to a different biologic treatment. As you can see, some of the biologics have different rates of side effects than others. The phase 3 Waypoint study was important because tezepelumab was just approved recently, and we see that for nasal polyp score as well as nasal congestion score, there was significant improvement compared to placebo. As you can see, over a 2-point change from baseline compared to placebo, and also for a nasal congestion score, about a 1-point change as well. So pretty significant improvements for tezepelumab compared to placebo. When you look at also the need for systemic corticosteroids, as well as the need to proceed with sinus surgery, you can see the dramatic differences with tezepelumab compared to placebo. There was significant decrease in need and decision to proceed with surgery. 0.5% the Tezi group compared to 22% in the placebo group, and the use of systemic corticosteroids, which is really important actually, where in the tezepelumab group, it was about 18% of patients compared to 5% of patients. So it's significant reduction of systemic corticosteroid use with tezepelumab. Some of the other improvement in the key secondary endpoints, this is some newer data, so worthy of sharing, that you can see for loss of smell, SNOT-22 score. I think that is the more impressive outcome measure as a rhinologist, seeing a minus negative 27-point change difference versus placebo. That's really impressive. Also, significant improvement in sinus opacification, total symptom score, and also for smell recovery, seeing that patients are able to smell again. That is an important outcome. And there's an open label study called Essence that is currently ongoing. We will hopefully have data from that soon. Some of the safety signals here, we see that it's quite safe compared to placebo. There were no significant differences that were detected. Let's talk about some newer emerging therapies for CRSwNP. There's another a monoclonal antibody called depemokimab. It's ultra long acting anti-IL-5 agent. It's only administered twice a year, so it may be really important and applicable and preferable for some patients who don't want to have to undergo a biologic or administer a biologic treatment every 2 weeks or every month even. So the phase 3 Anchor 1 and Anchor 2 studies are really important to show the improvement in the nasal polyp score and the nasal obstruction response scale score with depemokimab versus placebo. Overall, it was shown to be well tolerated. So we'll wait and see if this is an option for our patients. Stapokibart is another interesting medication, a monoclonal antibody, also similar to dupilumab, targets anti-IL-4 receptor, but in a different epitope, but is also similarly, because it targets IL-4 receptor alpha, able to block IL-4 and 13. It is slightly different, however. The findings from the Crown 2 phase 3 study showed that patients who have CRSwNP, they definitely had an improvement and reduced nasal polyp, as well as severity of their symptoms at 24 weeks. However, the adverse events were higher, although the serious ones were rare, but there was higher arthralgia and hyperuricemia with stapokibart compared to placebo. So let's look, just summarize this a bit to make it more digestible. If you look at some of just the indirect comparisons, these are all the trials that have been done for the different biologics. You can see on the y-axis And the difference in nasal polyp score, it appears that for sinus 2452 and for waypoint, so dupilumab and tezepelumab had the higher nasal polyp score change. However, this is an indirect treatment comparison. We still there is the Everest study that compared omalizumab to dupilumab, but still we do need better comparisons with different biologics that are head-to-head. The comparative effectiveness for nasal congestion score, we see also similarly that for dupilumab and tezepelumab that they had the highest effectiveness. What I do want to emphasize here, however, is that each biologic does a different thing. So, it is a little bit unfair to be comparing them like this, but I think it is nice to be able to summarize the data in this way. However, we do need better ways of comparison and to understand which biologic is best for which patient. So I'm going to hand this over to Dr. Higgins next.
Thank you, Dr. Lee. So I am going to look at how you identify patients for biologic therapies. So in determining who should get an initial treatment for biologic therapies, you need to look at some factors of the patient that you're seeing. Obviously, they need to have uncontrolled severe chronic rhinosinusitis with nasal polyps, and check to see if there's those comorbidities that have been alluded to with the other speakers, such as asthma or AERD, or also called NERD, and the consequences of those, because those may mean that they're needing multiple courses of corticosteroids or other treatments, and may benefit from a biologic for not only the reasons of chronic rhinosinusitis with nasal polyps, but the comorbidities. And check that they do indeed have type 2 inflammation, that it's highly likely. And then discuss with the patient. So I have an informed discussion of the treatment options, perspectives, risks of each of these therapies. And then when you can make a shared decision making of particularly whether or not surgery is indicated, a biologic drug is indicated, or both, I think you can now help with compliance and help with a better patient care. And then ultimately is selecting the biologic therapy of choice. So when talking about the comorbidities, some of these can overlap different specialties, such as asthma. You may want to talk to an allergist or a pulmonologist, or some a specialist who treats that condition quite often if you're not the one doing that. And there are a couple of different criteria that have been published that can help you with this decision-making process. There was an updated EPOS euphoria criteria. This looked at if a patient has bilateral nasal polyps and who underwent endoscopic sinus surgery, then if they have 3 of these criteria, that they would be a candidate for biologic therapy. This included evidence of type 2 inflammation, and for this, they had cutoff levels of tissue eosinophilia, the blood eosinophilia or total IgE levels. And then, did they need systemic corticosteroids, or were they a contraindication to systemic steroids, such as having at least 2 courses per year, or having a long-term therapy, such as over 3 months of low-dose steroids? Then looking at their symptoms, impaired quality of life. We discussed the SNOT 22. So they mentioned in our criteria greater than or equal than 40, indicating severe symptoms. And evaluating loss of smell. So if they have significant loss of smell, and especially evaluated by a smell test, and looking at the score of that. And then looking at those comorbidities, particularly asthma. So a diagnosis of comorbid asthma, and especially if they're needing regular use of inhaled corticosteroids, each of these may be criteria for a biologic therapy in chronic rhinosinusitis with nasal polyps. Another panel of experts also looked at an algorithm for deciding the therapy and treatment of chronic rhinosinusitis with nasal polyps. So In looking at that, it looks for an escalation of treatment. The majority of patients often will need endoscopic sinus surgery, and then looking at their postoperative management to make sure if you follow the patient and make sure that they have the best outcomes possible. A minority of patients will be contraindicated for surgery or have poorly controlled asthma despite oral corticosteroid dependent asthma, or they'll decline surgery and they may be a candidate for biologic up front. But if they've had surgery, then now escalating therapy to make sure that the nasal polyps or inflammation doesn't return, watching symptoms, watching objective findings. So if there are indicated comorbidities, such as asthma, as we discussed, they may already be a candidate for a biologic, not only for the CRSwNP, but also asthma. If they need revision sinus surgery, that may be an indication before or after or during to help prevent persistent disease, especially patients who have aspirin-exacerbated respiratory disease or aspirin sensitivity may be a candidate for a biologic because of the intense type 2 inflammation that occurs in them. Those other patients may need a steroid sinus implant, and bursts of oral corticosteroids are all kind of therapies to consider. Now, if they're persistent disease, then considering a biologic therapy and considering whether or not they would need repeat sinus surgeries versus biologic therapies and other therapies. The biologic use in patients for chronic sinusitis with nasal polyps remains low based on these studies. So only 12% have received approved biologic of the patients with CRSwNP, and yet the use of oral corticosteroids, antibiotics, and surgeries remain high, and that is even after the biologic initiation. And almost 50%, 49.3% of these patients will discontinue the biologic therapy. 65% of patients who receive biologics will still need oral corticosteroid use, and 77.9% antibiotics. And then also surgeries still may be indicated in these patients. So who would be a candidate for anti-TSLP therapy or thymic stromal lymphopoietin therapy that we discussed earlier? So look at patients who have recurrent or persistent severe chronic rhinosinusitis with nasal polyps despite optimized intranasal corticosteroids and prior endoscopic sinus surgery. They could have comorbid uncontrolled type 2 inflammatory disease such in the airway, such as asthma and AERD, especially if they remain symptomatic, or they're corticosteroid dependent and have failed surgery or at high risk, and an inadequate response to other biologic therapies. And so TSLP, one of the differences is it is an upstream epithelial cytokine, so master switch or alarmin, that sends the signal to the rest of the pathway, IL-4, IL-13, IL-5, and ILC2 pathways, to now modulate that broader inflammatory network. And so it can impact the inflammation at that epithelial layer and help with the structural remodeling. The data from the Waypoint study that was previously presented shows that there's a rapid and sustained improvement in nasal congestion score and nasal polyp score, including in patients who've had comorbid asthma, and it may be useful in prior pathway selective biologic to produce that have produced incomplete control or adverse effects. So how do you look at the response to biologic therapy if you do start it? One assessment looked at these 5 criteria. You can look at objective assessment of did it reduce the nasal polyp size, reduce the need for systemic oral corticosteroids, improves quality of life, improves sense of smell, and reduce impact of comorbidities. And if there's 1 to 3 of these criteria, it's a poor to moderate response. 4 to 5 of these criteria is a good to excellent response, or none of them as a no response. And then evaluate the response after 6 months and then after a year to see if you continue therapy or discontinue it. And you can evaluate whether or not they're a partial responder or a complete non-responder. So a partial responder will have some sort of subjective or objective improvement, and you can maybe continue therapy and monitor over time. Consider dose taper if there's a stable response. Or if there's a complete non-response, so meaning there's no improvement in symptoms, there's no nasal polyp improvement, then that may be an indication to switch biologic therapy, or they may need surgical intervention. And then the question comes up is, do you use biologics or proceed with endoscopic sinus surgery for chronic rhinosinusitis with nasal polyps? Or is there a combination thereof? So can biologics be used without surgery? Several of the clinical trials we've discussed do have patients with and without prior endoscopic sinus surgery, and they showed benefit. There was efficacy in both groups, suggesting that surgery may not be a prerequisite of biologic benefit. And it could be used, biologic could be used before surgery, after surgery, or throughout. So before surgery, the role would be to reduce inflammation and polyp size, potentially lowering the surgical burden. After surgery is to maintain that polyp control, reduce recurrence, and minimize the need for revision endoscopic sinus surgery. And this is an ongoing debate to be optimized in the future. Now I'm going to hand it back to Dr. Hahn.
Wonderful. So those were some really great overview from the immunology, the clinical studies that we have, and how to incorporate those biologics into our patients. So what I'd like to do is present some cases. We have 3 cases that we're going to overview, and I'd like to kind of go over them and ask our panelists, how they would manage the patient and what they would consider or think about. So this is our first patient, Brian. He's a 45-year-old man. He has a history of severe nasal polyps, had symptoms of nasal congestion and recurrent nasal polyps. He also has a history of asthma and allergic rhinitis. The patient underwent sinus surgery 12 months ago with some relief, but the polyps came back within 6 months. So the patient started on mepolizumab about 6 months ago with a background nasal steroid spray, and he still has ongoing congestion, loss of smell, and facial pressure. So Tom, hey, so when you see this patient, what are your thinking, and are there more information you want to get?
Sure. I think obviously a complete evaluation is necessary in this patient. I think especially starting off with a nasal endoscopy to evaluate further the symptoms of nasal congestion, loss of smell, and facial pressure. I'm looking for is there intense inflammation that's causing a lot of this? Is there potential of infectious processes that I need to manage first? Why is the patient not responding to mepolizumab right now? It appears, and then go from there to make a good decision.
Hey, Katie, I think, Tom brings up a good point because he's trying to understand the severity of the inflammation. How do you measure the severity of inflammation? Are there biomarkers you collect on patients? How do you decide that?
Yeah, that's a great question. So, I think a lot of the options we have are somewhat limited now, but there's still, I think, some good tools that we can use. So, for this particular patient, I would love to know pre certainly maybe even pre-surgery, but pre-surgery, certainly pre-biologic therapy, what were his peripheral blood eosinophil levels? Were they elevated? He's had this surgery a year ago. So, doing some additional kind of look back at the pathology for that and getting a sense of, if possible, the number of eosinophils per high powered field in the tissue might be helpful as well, just to kind of give a sense of how severe the inflammation was. And then I think there, is something to be said for also looking at serum IgE levels as a type 2 biomarker as well. So presumably because this patient was started on mepolizumab, he did have some elevation, at least in the peripheral blood eosinophils. But I think, putting it together with kind of the IgE might be helpful as well. We think about, patients with both high eosinophils and high IgE as having, lots of different type 2 inflammatory mediators as driving their disease.
Yeah, and I agree. I mean, those are biomarkers that I would kind of look for and ask the patient to have. And this is not an uncommon scenario. This is a very typical patient that was seen in the community by otolaryngologist. They did surgery, and then they have recurrence of the biologics, recurrence of the nasal polyps, even when on a biologic. And so, you know, Tom, one of the first things I would consider is getting a CT scan. Do you think is that unfair, or what do you do if because you're a rhinologist as well, and you probably get referrals from community otolaryngologists?
Yes, I think that's a good point. I think that would be based on a nasal endoscopy, and certainly if you see someone now with extensive nasal polyps from endoscopy, you can't really see around them. You want to see what's going on throughout the rest of the sinuses to gather also kind of what's been done from the sinus perspective, and then guide your therapy from there.
Okay. So this is a question I'm going to ask all three of you guys. So the patient has been on nasal steroid, intranasal corticosteroids. So what are your options for intranasal corticosteroids? Do you have a specific type, or do you have different options? Or can I ask, what kind of intranasal corticosteroids do you guys use? So let's go ahead and start with you, Katie. What type of intranasal corticosteroids do you use? Are there different types?
Yeah, this is a really good question. So, in somebody like Brian, who had surgery or go, I'll often work really closely with the rhinologist to come up with kind of a strategy that is both hopefully helpful and also tolerable for the patient. We often will use, steroid irrigation. So either respules or compounded steroids that we have the patient mix into saline irrigations and use that. We also have a lot of patients who are using exhale delivery system with fluticasone as well. So, we want to make sure that again, that they're tolerating it, not having side effects from it. But certainly for Brian, if he can do this, that would be something I think that would benefit him.
So it sounds like steroid irrigation, EDS fluticasone, Stella or Tom, do you use any other type of intranasal corticosteroids? Do you guys use steroid drops?
Yeah, I think budesonide or mometasone, there's several topical steroids that can be used as drops, especially when they come in the respule form. So, especially if there are polyps recurring in the frontal outflow tracts, I think that can be helpful. Um, so we try to administer the steroids in every, so I call it topical steroid yoga, many different ways to get the medication to the sinuses.
All right, thanks. Thanks, Stella. So now, Tom, now you have this patient, we've maximized the medical treatment. So what do we do next? I mean, do you continue them on the mepolizumab? Do you increase the dosing of it? I mean, what would you do for this patient?
I think for this patient with classic severe CRS with NP, I would and asthma, I would try a different agent at this point to see if he can better respond.
Katie, do you have a different opinion, or Do you agree?
No, I think that, yeah, that I think is definitely sort of I think a reasonable strategy.
Stella, I'm going to ask you, what if could we continue the patient on mepolizumab and do salvage surgery? Do you think that is an option?
Sure. I think throughout all of this, the discussion with the patient is really important. Um, some patients, want to have surgery, and changing too many variables at the same time can make it challenging to figure out what is helping and what is not. Uh, and patients often want to know, why something is not working. And also, I've had patients where a biologic doesn't work and they don't want to continue to pay for, that treatment if it's not helping them. So it's a discussion with the patient. Some patients do want to give it another chance and maybe combine it with sinus surgery, or switch to another agent, but it should be done in a stepwise, logical fashion, and there should be kind of a concerted plan in conjunction with your allergy, immunology, pulmonary colleagues.
Those are great discussions and wonderful. Let's go to the next case. So this is Sarah. She's a 52-year-old woman. She has moderate to severe nasal polyp with comorbid allergic rhinitis. The patient has symptoms of congestion, facial pain, and decreased sense of smell. She's not had any prior surgery, and she actually prefers not to do surgery if possible. So her symptoms remain difficult to control despite using intranasal corticosteroid. So Stella, what are your thoughts regarding this patient? I mean, what would you do next with this patient?
Yes, I have many patients like this. Um, I think for every patient, it's important to know what their biases are coming into a visit and why they might not want one um, modality versus another. And unfortunately, right now, there's just a lot of misinformation out there. So I start from the beginning. I go over, I just want to understand, why do you not want to have sinus surgery? Have you just heard from your friends or family they've had a bad experience? And what do you know about biologic therapy? Some patients are very savvy about having researched all the therapies, and they also actually come in asking for a particular biologic. So it's interesting, the whole spectrum. And I think for this type of patient who really we've gone through the risks and benefits of each treatment option, and the patient does not want to have sinus surgery. At least in the United States, it's not a requirement to for biologic therapy to have had at least one sinus surgery, although there is some guidance that every patient does deserve at least one good complete sinus surgery. So I do think that a biologic would be a good option for her. I would like to get more information regarding, we don't have a biomarker, but what are her comorbidities? We talked about allergic rhinitis. Does she have potentially asthma that's not diagnosed yet? What does her nasal endoscopy look like? What do her labs look like? So those are some things I would be thinking about.
Yeah, and I agree. I mean, even though she says she doesn't have asthma, that is something I would consider for her and say, does she have it or does she not? So Katie, what is a good way to evaluate? So someone comes in, she says she doesn't have asthma. She's a woman, she's got bad nasal polyps, she's got comorbid allergic rhinitis. How do you evaluate someone? How do you check if they have asthma?
Yeah, so that's a really good question. So, we take a good history, a good kind of respiratory disease history, and ask, questions that I think folks think about, like, oh, I have asthma if I'm, wheezing all the time, and I, get it with exercise or when I'm around cats or whatever it is. But we definitely see in a lot of patients with polyp comorbidity, they have adult onset asthma, and they may be used to having things like cough because they've had this upper airway disease, but certainly there could be a contribution of lower airway disease from that as well. So, we want to know, are they having any lower airway symptoms, cough, shortness of breath, chest tightness, wheezing? Are they having nocturnal symptoms? Are they, having kind of exacerbations where they'll have a productive cough for many weeks after something like a upper respiratory tract infection? So taking kind of a history in that domain. And then, in our office, we do spirometry. We can measure their pheno as well. So kind of inflammatory sort of biomarkers related to asthma, and get a good sense from that. And we often will meet patients where really the primary day-to-day symptoms that are impacting their quality of life most significantly are the upper airway polyp symptoms, but they're also having contribution of lower airway symptoms as well. And so depending on whether or not she has kind of poorly controlled asthma and it can't be controlled with kind of first line therapies, a biologic could be potentially helpful if she did have asthma for both the asthma and the nasal polyposis.
What is the role of methylcholine challenge? Is that even a role for this patient?
Yeah, that's a great question. So, we don't do it very often. I think it would depend on whether or not, if she had a lot of asthma symptoms and had obstructive physiology on her pulmonary function testing that was reversible with bronchodilator, we wouldn't really need to proceed with something like a methylcolon challenge. But it can be helpful when it's a really unclear diagnosis, and it's important to establish that there's the reactivity.
So, Tom, do you think this patient is eligible for a biologic? You think she would respond well to a biologic, even though she's not had surgery? And then to follow that up, if you were going to put on a patient on a biologic, which one would you pick?
So, great questions. First, I think this is a classic example of shared decision making. I think it's important to not try to force the treatment, but to inform the patient and have a thorough discussion, like Dr. Lee was mentioning. So, one is obviously to to discuss, what sinus surgery is, how it can be effective, and that sort of thing. If I do think that she could benefit and would be eligible for a biologic, especially with she will probably notice improvement in smell, improvement in nasal congestion itself. I would counsel her that it's very important for us to follow each other, to follow the disease state over time. At some point, she may elect that sinus surgery is an important next step, but we can definitely follow over time and go from there. Which biologic do I think that she would benefit from? Um, I think initially, based on the findings I have, I think dupilumab or tezepelumab would be great first choices for her. And we can discuss those and then go from there.
Wonderful. That was really wonderful points that everybody brought up. And so let's go to our last case. So this is a 16-year-old boy. So mind you, it's a pediatric patient. Tom was diagnosed with severe nasal polyp and comorbid asthma. The patient has symptoms of severe nasal obstruction and loss of smell and facial pressure. He underwent sinus surgery 18 months ago, had initial improvements, polyps came back 8 months later. In addition to intranasal corticosteroids, he received dupilumab 5 months ago for his nasal polyp and asthma. However, 3 months into the treatment with dupilumab, he began experiencing joint pain and rash, which led his parents to ultimately decide to discontinue the treatment. So let me stop there. And so Stella, what are your general thoughts when you're going over this case?
Yes. So the symptoms, want to know exactly, what symptoms are most important to him. It looks like he's having trouble breathing. He can't smell. Which symptoms improved? And it's interesting also how patients respond. The response to therapy informs a lot of also perhaps the disease pathogenesis. So if he did well with dupilumab, but unfortunately had the reaction, it's likely that he has a component of type 2 inflammation. However, the fact that the polyps recurred quickly is a sign that he has perhaps difficult to treat or refractory disease. So it means likely that he will need more extensive, thoughtful treatment. And I keep saying this, but these patients, I go back to the histopathology. I want to really understand the endotype for this patient, really investigate the comorbidities. It looks like here we already know he has asthma, but could he also have AERD, other things like that? And then once I really understand his the endotype, because he's had such a bad experience already, we have to be thoughtful about what we should do next. And I'll let Katie or Tom comment on the next steps for this patient.
So yeah, I was thinking, I think you're exactly right. I mean, what type of chronic sinusitis with nasal polyp is this? Yes, he has asthma, but the fact that he's pediatric, and let's say he lived in the Southwest, I would almost kind of think of allergic fungal sinusitis, right, Tom? What do you think? I mean, is that something that you see or think about in the pediatric population?
That certainly pops up as a consideration, especially given the locations. I think we can identify. Hopefully, we know something from his past sinus surgery. If we have a op note from there, that could be helpful. Or if we did it, then that would be even better. CT scan would be warranted to kind of better evaluate that, and the nasal endoscopy should be able to help us as well.
Okay, wonderful. And then, as you know, there are only two biologics approved in the pediatric population. The first one was dupilumab. When tezepelumab got approved, it also got approved for the age of 12 and older. So, Katie, what do you think? I mean, so this patient comes in, it sounds like he had a good response, but started having a little bit of side effects. And so, I mean, what do you do next for this patient? Because you only have two biologics to choose from, right?
Well, yes and no. So certainly for the polyp indication, we know that it's 12 and up for patients with chronic rhinosinusitis with nasal polyps. And I think given, what we know in terms of what is really, symptoms right now where he is having, this nasal obstruction, loss of smell, that tezepelumab would potentially be a good option for him in terms of both his upper airway disease and then also his asthma. Because he has asthma, depending on the severity, he could potentially be a candidate for biologic therapy for asthma as well, which would open up some other options. So, in patients who have asthma comorbidity, I kind of like to think through a little bit like, what is their primary problem and primary goal, what's bothering the most. For, Tom, it sounds like it's really the loss of smell, obstruction, facial pressure that's bothering him. So I think that tezepelumab would be potentially a great option for him. And, I think that we're going to see more real world data and certainly more switch studies that are published. I'll just say, like in my personal practice, I have a lot of patients who for whatever reason, were intolerant of, one biologic that we have switched to tezepelumab for asthma specifically, and they have done really well. So reacting to, in his case, dupilumab does not necessarily preclude that he can go on to an alternative biologic therapy, which is really nice. And I think, being open-minded about the potential indications for him will hopefully give him a good array of options to choose from that kind of, fit his goals in terms of his long-term treatment plan.
Yeah, I think that's a great point because I think, I always only think about the nasal polyp, but you're right. Asthma definitely has other um, um, indications in the pediatric. The other biologics for the pediatric asthma patients. So that's a great point. So it looks like we're coming to an end. So I hope you enjoyed our presentation, and based on what we've discussed, I think is chronic sinusitis with nasal polyp is a type 2 inflammatory disease. Sometimes they can be refractory to conventional treatments. Um, we know that these patients usually have overlap with asthma. There are 4 approved biologics for dupilumab, omalizumab, and most recently tezepelumab. And tezepelumab targets TSLP, which is an epithelial cytokine, and can drive type 2 inflammation. There are more biologics coming down the road. It's nice to be able to have a lot of different options. And having a lot of different biologic options, I think, allows us to kind of personalize what we can choose for our patients. So I'd like to thank you so much for joining us today. And I'd like to thank Dr. Buchheit, Dr. Lee, and Dr. Higgins for providing such a wonderful insight and great discussion. We hope you found this activity to be useful to your practice. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from AstraZeneca Pharmaceuticals. To access all materials for this activity, visit peerview.com/ZYK860.